Hello, I'm Dr. Christian Hunter. I'm here with Professor James Januzzi. Thank you for joining us.
Yeah, thanks. It's really great to be here. It's great to, talk a bit about the natriuretic peptides and how we got to where we are with them clinically.
Yeah, we've been looking forward to this. Can you tell me more about the natriuretic peptides?
Sure. So the natriuretic peptides are a highly evolved endocrine system that we've known about for quite a long while, actually. In fact, philosophically, the concept of the heart as an endocrine organ came up 60 years ago. But it took until the 1980s before Adolfo de Bold identified the presence of natriuretic factors that were present in the myocardium of atrial homogenates. We subsequently recognized that those factors were in fact proteins, peptides, and the atrial natriuretic peptide, being the first to be identified, is one of the family of the natriuretic peptides that are found in circulation. And in fact, they're actually present in numerous species, very similar to human, and they play a really important physiologic role in the regulation of salt and water handling, blood pressure, vasoconstriction. The biology of it is really quite interesting, actually. And when you look at the expression of the BNP gene, what happens is an intracellular precursor protein is produced. It's 134 amino acids, but that gets rapidly cleaved, yielding an intracellular precursor called proBNP 108. ProBNP 108 is then cleaved by furin and corin, and from that is released into the bloodstream the amino terminal peptide, NT-proBNP, and the C-terminal peptide, BNP. Now, BNP is the business end of the molecule. It binds to the natriuretic peptide receptor. There are several natriuretic peptide receptors, in fact, but BNP binds to the A receptor. And that's important because the A receptor, through second messenger function, results in all of the biological goodness that BNP exerts. So BNP, although people often think of a high BNP as being a bad thing, it's being released for a reason. It's actually a mayday hormone to unload the heart. So it causes salt and water excretion, it vasodilates, it reduces fibrosis in the myocardium. All of this transduced through the A receptor. Now, of course, the biology is more complicated than we originally thought. I mean, originally we thought that proBNP 108 was cleaved and released as just a one-to-one NT-proBNP and BNP. But it turns out, in fact, that BNP, being biologically active, we probably should have realized this very early on, the body wants to get rid of it, right? As a true endocrine process, there are clearance mechanisms that are quite active. So BNP gets degraded very quickly by numerous enzymes in the bloodstream, resulting in a mixture, actually, of different fragments of BNP. They're all still measurable using the BNP assays that we use, which means that the tests that we have for BNP still hold and are still quite useful. In addition, we now also know that a substantial percentage, particularly in advanced heart failure, of the circulating natriuretic peptide is that proBNP 108, which is not biologically active. And there's a lot of interest in trying to understand how the shift from active natriuretic peptide to proBNP 108 occurs and how we might, try to help patients do better by converting 108 to a more active form. Now, when we think about why the heart releases natriuretic peptide, it's important for clinicians, scientists, laboratorians to remember that as with many things in medicine, it depends on where and when the test is measured. If a person is coming in with acute shortness of breath, say to the emergency department with acute heart failure, the big driver of release is myocardial stretch from volume overload, fluid. Right? And this is really the paradigm that we thought of natriuretic peptides back when we first started measuring them. Oh, they're a measurement of congestion. And that's true. But it turns out if you measure in a more stable patient who's been decongested, then what happens is you subtract out a lot of the signal that's driven by congestion, and then you start detecting the things that cause natriuretic peptide elevation besides congestion. And that includes abnormalities in the left heart, so left ventricular systolic function, left ventricular chamber size. Importantly, the right heart also matters. So right ventricular size and function really matter a lot in patients, for example, with pulmonary hypertension. natriuretic peptide concentrations are often very elevated, and they're often very prognostic. Valvular heart disease, filling pressures, individuals who have pulmonary hypertension, sleep apnea with periodic surges on pulmonary pressure, all of these factors can determine natriuretic peptide values. So clinicians really need to remember that it's not just heart failure that determines natriuretic peptide values when you're measuring in patients presenting with various symptoms and signs. And, you know, to be honest with you, when we think about anything from a diagnostic perspective in medicine, there should be a differential diagnosis, right? And, you know, we learn this in residency and fellowship. You know, you can't just assume that an abnormal BNP or NT-proBNP is heart failure. And with that knowledge, a clinician is much more forearmed with respect to understanding how to interpret the lab results.
What are the main clinical differences between the NPs?
Yeah, you know, it's interesting. We've thought an awful lot about the clinical differences between the natriuretic peptides over the years, and certainly back when we first started measuring them, you know, we recognized there were differences. But I would start off by saying they're actually more similar than different. You know, if we go, rather than, you know, thinking about particular details and really think more about the clinical use of the tests, man, they overlap pretty one-to-one, right? You know, so whether it's acute heart failure diagnosis, prognostication, monitoring in, you know, chronic heart failure as well, risk prediction in ambulatory unaffected by heart failure patients. Yeah, they pretty much tell the same story. The key, though, and I think we can talk more about this as we have more discussion, is that you need to understand how they differ and also how to interpret them, because they're not a one-to-one interpretation. So, first of all, it's important, as I've already sort of mentioned, you know, BNP is biologically active, and so as a consequence, the body wants to clear it. NT-proBNP is not biologically active. Accordingly, you know, we don't really know the exact number, but the half-life of BNP is probably about 1/3 that of NT-proBNP. We say that it's about 20 minutes, NT-proBNP is about 90 minutes. That changes depending on how much is released. It changes about with how the kidney function is. You know, there are a number of different factors that determine their values. What's interesting is if we measure BNP and NT-proBNP in healthy people, they're actually pretty similar. And that speaks to the fact that the B-type natriuretic peptides, unlike the A-type natriuretic peptide, the B-types are synthesized when needed. So they're not stored and released on trigger. And so the basal secretion of BNP is very low. And so in health, they're very similar in number, but in disease, that's where they diverge. So clinicians need to understand that if converting from BNP to NT-proBNP, which we can talk about, there's a bit of a learning curve because the numbers will be different. And because of the half-life difference, the rise and fall is different. And so these are all factors that, you know, people have noticed when comparing the two. But again, I come back to the fact that clinically speaking, they are very, very interchangeable. Now, how do they differ? Well, you know, they differ in a number of different ways, but, you know, clearance is something that we've talked a lot about. There's been, I think, probably an evolving, to be generous, understanding of how NT-proBNP is cleared. You know, early on, people sort of said, oh, it's just cleared by the kidneys. Well, it's not true, actually. We and others have shown that the renal dependence on clearance of NT-proBNP is exactly the same as BNP, and it's about 20%. And that makes some sense, actually, because they're small molecular weight proteins. They really, neither of them are dependent on glomerular filtration, really, for their clearance. On the other hand, we also know that NT-proBNP is cleared by organs with high blood flows. So it's cleared by the skeletal muscle, the reticuloendothelial system. So it's not well understood, but we know that it's not just the kidneys. And that's an important point because one of the things that people struggle with is how to interpret an elevated NT-proBNP in somebody with chronic kidney disease. And it gets down to, again, more importantly, the difference in half-life. If you've got reduced clearance and a longer half-life, it's going to appear to be, quote, more affected by kidney function than a peptide with shorter half-life, right? On the other hand, BNP also has some quirks about its clearance. One, and very importantly for clinicians to understand, is the fact that all of the natriuretic peptides, the biologically active ones, are cleared by neprilysin, which is an endogenous metalloproteinase found everywhere in the body, but mainly in the kidneys. And neprilysin is important because we inhibit neprilysin when we treat heart failure now. And neprilysin, which cleaves ANP, BNP, and CNP in multiple places, when inhibited, results in some effect on circulating natriuretic peptide concentrations. Now, we know that NT-proBNP is not affected by neprilysin inhibition, at least with respect to its clearance. On the other hand, NT-proBNP reduction in the setting of neprilysin inhibition is an important signal that the drug is working. With respect to BNP, there's been some confusion. The early data with neprilysin inhibition, the Paradigm HF trial, which looked at sacubitril valsartan versus enalapril, suggested that BNP rose by around 20%. And that led people to sort of say, whoa, I don't know if we can use this biomarker anymore because, you know, we're using this drug, sacubitril valsartan, an awful lot. We looked at this, and many others have since, and really have found that it doesn't really cause a whole lot of increase in BNP when you're treated with neprilysin inhibition. But on the other hand, it doesn't decrease very much, and so it sort of hovers. And then over time, as the heart improves and release goes down, then the BNP will gradually taper. So it's important for clinicians to understand that there is going to be an effect, but it may not be as dramatic as previously feared. Now, one important point, and this is maybe getting a little bit on the lab side for clinicians, we often don't think about the different assays that we measure natriuretic peptides with, but to the extent that neprilysin cleaves BNP in multiple places, and those places just so happen to be where the antibodies for the various immunoassays for measurement of BNP tend to bind, we ask the question, does neprilysin inhibition affect different BNP assays differentially? And what we found was, in fact, that the answer is yes. It looks as if the Abbott assay is the least affected with a gradual decrease after treatment with sacubitril valsartan, neprilysin inhibition, whereas other BNP assays may be somewhat more affected with a rise and then a taper. So, you know, I guess what I would say is that, you know, this understanding is evolving, but to the extent that neprilysin inhibition is evolving rapidly and becoming more and more used, it's necessary for clinicians to understand this.
Okay. What are the clinical guidelines for thresholds and or cutoffs?
So the clinical guidelines are clear. You know, the natriuretic peptides play a key role in a number of different applications in heart failure and in other areas, but in heart failure particularly, they are the gold standard blood test. There is no disputing at this point with a class 1A for diagnosis and prognosis in heart failure. And in addition, there's recognition of the importance of natriuretic peptides for other applications, including assessing when a person might be ready to go home from the hospital, which I, as a clinician, find quite useful. There's interest in trying to understand how we can measure natriuretic peptides in apparently healthy individuals, or let's say individuals apparently unaffected by heart failure, because they may not necessarily be healthy. They may have a risk factor like high blood pressure, diabetes, and higher levels of natriuretic peptide in those individuals have been shown repeatedly to predict onset of heart failure. And then the role of natriuretic peptides in heart failure therapy adjustment is something that we use on an everyday basis to help make decisions about treatment. Now, to be sure, clinicians know natriuretic peptides are very useful for diagnosis of heart failure. A person rolls in the emergency department with shortness of breath. And you asked about cutoffs. There is a simple way to approach this, and then there's a more complex way to approach this. The simple way is to use a single upper reference limit. BNP was released with a single upper reference limit of 100. When we did the PRIDE study, which was the first NT-proBNP study, we found that the single best cutoff was 900. So again, as we've discussed, owing to the longer half-life, NT-proBNP circulates in higher values typically. And so, 1 to 9, 100 to 900 is sort of a conversion we often see, 800, 900. So a single cutoff performs pretty darn well, actually. Good sensitivity, good specificity, good positive likelihood ratio, very good negative likelihood ratio. If you're below that value, you're very unlikely to have heart failure. But the problem is, we trade some things off when we use a single cutoff. And in particular, with older individuals, we trade off specificity, because age is an important predictor of higher natriuretic peptide values. On the other hand, in younger individuals, lower values, you take somebody who's under 50, if they've got a BNP of 50 or 60 or an NT-proBNP of 400, 500, that's very abnormal. So we sought to examine this question about the effect of age and try to sort out a more accurate cutoff strategy. And in the ICON study, we showed that when you're healthy, you're healthy. So a low value, regardless of your age, excluded heart failure with high negative predictive value. On the other hand, recognizing that age was the most important predictor of a BNP being above 100. And by the way, after BNP was released with a single cutoff of 100, many people recognized that between 100 and 500, the positive predictive value wasn't perfect. And so we talked about the so-called gray zone with BNP, where 500, when you're above that, then you very likely had acute heart failure. The key is recognizing that age was the single strongest predictor of being in the gray zone, right? So we looked at an age stratified approach for NT-proBNP, finding that this was clearly superior to a single cutoff, improving sensitivity for younger individuals and improving specificity for older individuals. So this so-called triple cutoff for NT-proBNP is now in use globally, much better than using a single value. For prognosis, there is no better available blood test commercially than natriuretic peptide. It's a more prognostic measure in heart failure than kidney function. It's a more prognostic measure than age, believe it or not. And so we now widely apply natriuretic peptides for prognosis. And in addition, to the extent that prognostication in the hospital is about making sure you treat patients adequately before releasing them back to the outpatient setting, there's growing use of natriuretic peptides, as I've already discussed, for pre-discharge risk assessment. Now, I as a clinician find that to be very useful. We get a natriuretic peptide on admission, we get one on discharge. And I particularly, rather than looking at a hard target of, is it below X, what I look for is a change, a percent change. A 30% reduction during heart failure hospitalization is associated with favorable short to intermediate term outcomes. But the answer is remembering that the release of BNP or NT-proBNP in acute heart failure is driven by congestion. The fact that a 30% reduction is associated with a better outcome just says to the clinician, you've successfully decongested your patient, right? And that gets us to where natriuretic peptide use is just going through the roof now, which is in the outpatient setting. We've been measuring them in the hospital for years, but the outpatient setting is a place where we're really starting to see real value. And that's because if you have a pre-discharge value, you've got your bridge from the hospital to the office. And since we're seeing patients in the office within a week or two after heart failure discharge, it provides us a really good thread to connect the hospital to the office. And in the office, concentrations of BNP or NT-proBNP are wildly prognostic, with lower values, particularly after heart failure management. I think that's key, because what we're really saying here is don't just measure it because you're interested in seeing what the number is. We're saying treat your patients to the optimal medical therapy you can deliver, and then after treatment, reassess natriuretic peptide response. And in the guided trial we showed there was really no NT-proBNP value that was too low. The lower you went, the lower the risk. And importantly, remembering that in chronic heart failure, this is less about congestion and more about structural heart disease signal. The lower the natriuretic peptide value after treatment, the better the left ventricular function in people with reduced ejection fraction heart failure. So people who had large reductions in NT-pro after treatment had the largest improvements in ejection fraction, the largest reductions in LV volumes. And we see this again and again in our guideline-directed medical therapy clinic. So what we tell our clinicians is, in recently decompensated patients that you're seeing in the office, we try to see them within a week or two anyway, remeasure a natriuretic peptide, and then get them into your guideline-directed medical therapy stream, get their medications optimized, and reassess labs as you go. For stable, and I hate to use that word in heart failure because there really isn't any such thing as a stable heart failure patient. That's like a contradiction in a sense, but in individuals who are, without worsening symptoms or hospitalization, we recommend monitoring about every 3 months or so. For those that are stable with low values, say an NT-pro less than 1,000 or a BNP less than 100, those individuals are not your problem. They are folks that are very unlikely to have hospitalizations. Their left ventricular function is very likely to be improving in the context of guideline-directed medical therapy. And so you can withhold high-cost imaging and other aspects in those folks. On the other hand, if you identify people with an elevated or rising concentration, and this is a question that's going to come up, which is what do you do when the value is rising and the patient says they feel fine? Well, we've learned that those individuals are remodeling. Their heart is not happy even if the patient says they feel okay. So it's important to keep them on your radar, keep an eye on them, make sure their medications are optimized. For those with markedly elevated concentrations, those are the people you're really going to focus on, whether it's an advanced heart failure referral, whether it's re-imaging, right heart catheterization, consideration for transplant, and importantly, remembering the differential diagnosis of an abnormal natriuretic peptide. There are certain diagnoses we don't often think of right off the bat that can lead to higher values. Clinicians need to remember, for example, that cardiac amyloidosis, which now has a very effective set of treatments, often leads to unexpectedly high natriuretic peptide values. So when we see those very high values despite attempts at medical management, think about hidden diagnoses like amyloidosis or other aspects.
So when you transition from one to the other, any advice?
Yeah, I mean, this is an issue that comes up a lot now because most of the in vitro diagnostics companies have a BNP assay or an NT-proBNP assay. And so clinicians now can choose, which I think is really great. Having the freedom of choice is really important. The issue is that it's not simple. It's simple for the lab to change out an assay on an instrument. It's not simple for clinicians. And I think, it's important to keep in mind that the complexity is very well addressed with preparing for the switch and education. I'll talk about that in a second. But one question that often comes up is, well, do you ever use both peptides in the same institution, or do you overlap them when you transition? So first of all, there are some regions of the world where you can actually get both BNP and NT-proBNP, and clinicians just choose. What I will say is I'm not sure that that's necessarily the most efficient use of a laboratorian's time. The truth of the matter is, because of the overlap is so gross in terms of the similarities of indication, one can do what the other one does. And so, clinician comfort may drive that decision more than anything else. A question has come up about, do you panel them together? Do you look at the ratio of one over the other? And those are all, I would say, research-based. I wouldn't do that clinically. So it really comes down to deciding what's best for your institution. What instruments do you have? What do the clinicians have comfort with? There's, I think, a really good argument for integrated health networks to go universally with one assay, because if a patient goes from one hospital to the next and they use different assays, that can be problematic because they do speak different languages, as I've said. So it's important for laboratory directors to think about this. But I cannot emphasize enough how important it is for lab directors not to just make a switch without warning their clinicians and educating them. Besides preparing the lab for the change and preparing the laboratory information system to switch to different cutoffs, letting clinicians know that an assay is being changed is critically important. We measure dozens of NT-proBNPs a day. When I say dozens, I mean probably over 100 a day. So if you go from one assay to another and all of a sudden they have different kinetics, rise, fall, different reference ranges, it can be very confusing. So I strongly urge lab directors to make sure that clinicians know this change is coming and educate. Work together with clinicians, the stakeholders, as we say, the emergency department, cardiology, internal medicine, to develop protocols around the measurement, and then educate again. And then lastly, I say this again and again, always make sure to come back and assess your performance a few months down the road. Now, of course, you have to choose a natriuretic peptide assay. That's fine. That's shared decision between clinicians and lab directors. Sometimes the decision's easy. If a lab director has an Abbott system, they're going to use the Abbott assay, and that really then comes down to which natriuretic peptide you want to use. The other question is, does point of care testing matter? Some institutions live and die by point of care testing in their emergency department, others do not. And so trying to work with clinicians to understand that if you switch to an assay that does not have a point of care option, they may not be able to have it right then and there in the emergency department. You work through this, you get all stakeholders on board, making sure that they understand that reference ranges will change, concentrations will change, and then you can consider different approaches for launch. When we went live, we just launched. But some institutions will gradually introduce the assays and possibly overlap so that clinicians can learn the differences. One is not better than the other. They are different, and that's the most important key to remember, is that they do behave somewhat differently. So having clinicians be prepared, educated, working on protocols, understanding the similarities and differences, and then making sure that you do these repeated educational efforts is really important, because then when you launch, you can't go back. I said this again and again to lab directors, you're never going to be able to go back once you launch a new assay.
All right. So what does the future hold?
Well, the future is really, I think, pretty bright actually for lab testing in general. The old statistic that something like 80% of medical decisions are supported by some form of a diagnostic test, I think that number is probably going to increase. And the reason why is because we're now starting to recognize that using blood tests like the natriuretic peptides, we can identify a molecular signal of risk that may be present with no other measure being abnormal. Completely normal echo, but an abnormal natriuretic peptide. And those patients have risk. And that now really is reflected in the guideline recommendation by the ACC, AHA, and Heart Failure Society of America, as well as other societies, including the American Diabetes Association, for measurement of natriuretic peptides and high sensitivity troponin, by the way, to identify risk for heart failure onset and potentially intervene and reduce that risk. And the idea is that unlike an imaging test, which is abnormal after the damage has occurred, natriuretic peptides may rise before obvious myocardial injury is really present. I mean, obviously, if troponin is up, for example, there's injury, but it may not be enough to cause imaging changes. So it may be early enough that heart function really is very normal. But this biomarker-based detection, early detection, I don't like the term screening, early detection of heart muscle stress or injury is a critical finding, and in fact was built into the universal definition of heart failure as a measure of risk for a heart failure onset. There are different ways to identify risk in the office, utilizing a blood test for NT-proBNP or BNP, and there are many interventions that we can afford to our patients now. For example, the individual with diabetes and a heart failure risk clearly initiation of a sodium glucose cotransporter 2 inhibitor, a GLP-1 receptor agonist, people with diabetic kidney disease, a non-steroidal mineralocorticoid receptor antagonist. These therapies have been definitively shown to reduce heart failure onset. Now, another place where things are evolving is also in the heart failure world. I mean, you know, let's say we've shifted now from heart failure prevention, now we're looking at the patient who actually has heart failure. For years, we've been measuring natriuretic peptides in the emergency department. For years, we've been measuring natriuretic peptides in the office, but one place that we haven't really been able to get to is in the home. The reason why this is important is because we now know from studies, for example, from the guided trial, that measurement of natriuretic peptide can identify individuals at risk for heart failure events weeks to months before the event happens. And so if we had a scalable way to monitor more closely in patients who aren't in the office or who aren't in the emergency department, it might help us to identify risk at a much earlier time frame. And now there are home-based finger stick methods coming for natriuretic peptide testing. There are several vendors now working on this. These tests will allow for measurement of natriuretic peptide in the home setting. And of course, you can envision above and beyond the use of this test to measure natriuretic peptide for heart failure management in the home. We can do it, we can potentially utilize this technology with home hospital approaches, rural care of patients where healthcare resources are not widely available. So it essentially democratizes biomarker measurement to a population that hadn't been able to get access before. So it's really exciting to sort of see where we're heading with respect to both, you know, prevention of heart failure, but better care of heart failure with delivery of these tests to populations that previously hadn't been measured before.
Yeah. Great, thank you so much.
Yeah, thanks for the opportunity to chat today.
Yeah, really interesting.
Thank you.